Okay. Again, good afternoon, everyone. Welcome to the Healthcare Cost Transparency Board's 2025 data call. This is the webinar for carriers. Hope you've come to the right place. Really excited for today's webinar where we'll be going through all things related to data submission for the 2025 data call. Before we get started, I'd like to do a quick round of introductions. We have the entire data call team here. I am Harrison Fontaine. I'm a policy analyst that supports both the data call and the cost board's work, and I will pass it over to Ross.
Thank you, Harrison. Ross Valori. I am the Director of Board of Commissions here at HCA, and I'm really pleased to be working with these other really talented colleagues on the call who have been doing a ton of great work and have a great presentation for you today. Yeah, just please let us know if there's any questions that come out of this. Happy to help and hoping this webinar is helpful for you. And again, just wanted to shout out again this team for all your hard work getting us here and for this presentation. So thank you. And we'll pass it to Ping.
Hi, welcome to the webinar. I'm Jinping Shing. I'm the Cost and Quality Analytics Manager in the Healthcare Authority. You might have worked a lot with us in the past 3 years about the data call, and we are the team to provide data support for the cost board. Next, I would like today's presenter from the data team to introduce themselves. Cheryl.
Yes, thank you, Jinping. Hi, everyone. Cheryl Namingit, the Health Economics Research Manager within the data team. And so pleased to see everyone again today. I'll pass it on to Ross. Not cool, because we have many Rosses.
Hello, everyone. I am Ross. I'm an analyst. Hopefully, I've met a lot of you before, and if not, welcome to the carrier webinar. We'll have a lot of good information for you, and I will pass it on to Marty.
Yeah, hi, Marty Ross, yet another Ross. I'm a healthcare analyst here at the Healthcare Authority. So I'll hand it over to Kathy.
Everyone, I'm Kathy Temple. I'm also an analyst with the Cost Board data team. I'm the newest member of the data team, and welcome. Glad to see you today.
All right, and with that, let's dive in. Next slide, please.
One second, Harrison, as I get situated.
I can see you working on it. Thanks.
All right.
There we go. Okay, so before we get to the good stuff, just a quick lay of the land. For today's goals, really the goal of today is to assist you, to be helpful to you as we begin to support you in responding to the 2025 data call. So we're going to provide you with some technical updates. We will be answering your questions and we'll be providing an overview of the submission template that will really form the foundation of your submission. I'd like to note that we have some changes to the slides, very minor, but the updated slides and a recording of this training will be posted to the data call webpage, and you can see the link here. And again, we'll be sharing these slides on the website afterwards. Next slide, please. So a quick overview of today's agenda. We'll talk about what the Healthcare Cost Transparency Board is, then we'll talk about the data call. We'll talk about reporting timelines, discussion of the data call materials, including, again, those technical changes, looking a little bit at the nitty-gritty of the technical manual. We'll be looking at the submission template and some specifics there. And then we'll have a special focus to things that have changed since the last data call submission. We'll also go over suggested consistency and trend checks so that we can be sure that you're submitting quality data. And then we'll finish off with submission reminders, reminder about office hours, and a chance for Q&A at the very end. Next slide, please. Okay, so beginning to talk about what is the benchmark effort and the Cost Transparency Board itself. Next slide, please. So the Healthcare Cost Transparency Board was established in 2020 by a state law that charged the cost board, there are cost boards in many other states too. It charged the Washington State Cost Board with doing a few things. One, with establishing a healthcare cost growth benchmark, which really serves as a target percentage to keep cost growth under. Along with this, analyzing total healthcare expenditures with identifying trends in cost care growth, and then identifying entities that exceed the healthcare cost growth benchmark. Lastly, the board is also charged with providing recommendations to the legislature in an annual report to the legislature. And additional information on the broad charge of the cost board is through this link on the cost board webpage. Next slide, please. Okay, who is the cost board? The cost board is essentially comprised of governor-appointed experts and representatives for purchasers, consumers, and also, importantly, state agencies. It is advised by now 3 formal committees. We have an advisory committee that focuses on data issues. We have an advisory committee that is focused on stakeholder issues and is really formalized in who is part of that advisory committee. And then lastly, we have an advisory committee focused exclusively on primary care and how that fits in with the other efforts. And again, the efforts of the cost board and these policies to contain cost growth are summarized in an annual report to the legislature. Next slide, please. So we're here to talk about the data call, and the data call allows us to compare rates of growth to the benchmark. And this benchmark is an annual rate of growth target, again, for total healthcare spending in the state of Washington. And it's really based on 2 things. It's based on historic median wage growth and per capita gross state, per capita potential gross state product, or PGSP growth. Say that 5 times fast. And you can see here the benchmark values for some past and oncoming years, and that is what we'll be comparing your data to. Next slide, please. So this cost growth benchmark really allows us to inform the efforts of the board. In doing so, we are essentially measuring performance relative to the cost growth benchmark. We're analyzing and looking at cost growth drivers and cost growth trends within the state. That informs reports that inform that overall legislative report that I've mentioned. And then it also allows us to identify really targeted strategies and opportunities to contain cost growth, an effort that we're all really interested in. And we can then implement those strategies as part of these efforts within Washington State. And the cycle repeats. Next slide, please. So at this point, I will hand it over to these fantastic experts that you've already met, and they will discuss the 2025 data call specifics.
So I will start the discussion on the specifics of the data call. This year's data call, 2025 data call, is the 3rd data call that the cost board has implemented. As you can recall, the first one was implemented in 2022, and the last one was conducted last year where we collected data from carriers and non-carriers. So an overview of the 2025 data call, we're going to collect 2022 and 2023 data this year. While we already collected 2022 data last year, we are recollecting 2022 data again this data call. This new 2022 data and 2023 data should be aligned with the new primary care definition. So given that they're aligned, the new 2022 and 2023 data, when we calculate the 2023 cost growth that we compare to the benchmark, the growth rate should not be impacted by the primary care change, primary care definition change, as well as other changes. The collected data will be added to the historical data that was collected in the last 2 data calls. In particular, we have 2017 to 2022 data. And then like last year, we will calculate the cost growth for the overall statewide performance. We're also going to calculate carrier performance as well as large provider organization performance, and then compare it to the benchmark when we report it at the end of the year. So now for the timeline of the data call, we started with the launch of the data call last February 18 when we sent the data call letters and several links to the updated materials. And then carriers and non-carriers who are submitting data have at least 3 months to prepare the data. The deadline for data submission will be on April 18. Once we receive the data, we will conduct data validation from April to June. After we validate the data, we're going to conduct analysis and generate provider and carrier reports, and we'll share it to carrier and providers from July, within this time span, July to October. And then once we are done with that, we are going to report publicly on statewide performance, carrier, and large provider performance against the benchmark in November. So to aid submitters on how to submit data, we have written up and updated the technical manual, which provides more details on the program as well as a data submission guide for submitters. And we will talk more about this in the latter slides. We also provided a data submission template, and this is an Excel file that submitters have to download and populate and submit for this data call. We also have frequently asked question page that answers frequently asked questions. And as we receive more data, we will try to update this page regularly. So please continue to look at the FAQ page in our data call webpage. So before we go into these data call materials, I would like to provide a summary of the major technical changes that are being implemented this year. As mentioned earlier, we have updated the value sets for primary care to align with the definition that is newly approved by the Cost Board's Advisory Committee on Primary Care. We also specified that while the minimum runout period is 180 days, submitters should use the maximum amount of runout time so that we will be able to receive and analyze the most recent data from carriers. Also, we have asked carriers to submit doing business as names and federal employer identification numbers, or EINs, in the cover page submission starting this data call. These are just 3 of the changes, but these are the major changes that are being implemented this year. But for a complete list of changes in the technical manual, you can see it in page 1 of that data call material. And then moving forward, slides that are new or contain update relative to what we presented last year has a new or updated sign at the top right side of each slide. Of the slide that has changes. Okay, so let us talk about the data call materials in greater detail, in particular, the technical manual. So the technical manual is divided in 3 sections. The first section provides an overview of what Harrison described earlier, the calculation of the benchmark or the target for the cost growth. And then, as he mentioned earlier, the benchmark is determined by a combination of economic metrics, particularly the combination of wage growth and the growth rate of per capita potential state income. The second part of the technical manual discusses how we measure performance against the benchmark. And I want to also mention that aside from the technical manual, we also have more detailed documentation on carrier and provided reporting methodologies in the Cost Board's webpage. So in particular, this link contains very detailed calculation on how we calculate age and sex risk adjustment for carriers and providers. It also explains how standard deviations are pulled together to be able to get the overall standard deviation for carriers and providers, and how the confidence interval for the cost growth is calculated. The third section of the manual discusses how how data submitters should prepare and submit the data. And so to do so, submitters must correctly populate and submit the data submission template, which we will discuss in the next slide. I would also like to emphasize that submitters must use the most recent or the updated data submission template that can be found in the 2025 data call webpage. All right. Going to the data submission template. As mentioned earlier, this is an Excel file that you can download from our webpage and that you must populate to be able to submit the data. This Excel file has 6 tabs. These are the cover page, the total medical expense tab, the standard deviation tab, the line of business or the enrollment by line of business tab, the RX rebate tab, and the last but not the least, the list of reference tables. For the next slide, we are going to discuss the cover page and what you need to input in the cover page. And then we will present, then we will proceed to the TME tab, where we will explain the data stratifications required, specifically that the data has to be grouped by carrier code, reporting year, insurance category code, large provider entity code, age band code, as well as sex band code. We'll also discuss the various data fields that need to be filled out here, in particular, the member months, the different categories by claims and non-claims, as well as untruncated and truncated claims. So since we have encountered numerous errors in the past data call, we will again provide more explanation and examples on how we do truncation so that submitters could correctly calculate the truncated claims spending. Then we'll also discuss the third slide, which is a third tab, which collects information by carrier code, reporting year, large provider entity code, market code. We will collect member months, total truncated claims spending. But the new these member months and total truncated claims spending are also in the 2 TME tab. But the new thing here in the standard deviation tab is really the standard deviation of truncated claims spend PMPM, which we will use to be able to calculate the confidence interval of the cost growth of carriers and providers. Then the 4th tab collects member months, but this time it is by carrier code as well as the line of business categories. Then the last data collection tab is the tab where carriers or data submitters would input data on pharmacy rebates by medical pharmacy, retail pharmacy, and total pharmacy by these various stratification codes. And then we'll always reference to the different data stratification groups to the reference tables. So after that long introduction, I'm going to talk about the contents of the cover page. So in this page, carriers are asked to provide the contact information of an individual who would be our contact person during the data validation process. In addition, this page also contains a section where carriers are asked to provide to confirm estimation methodologies that are used in the calculation, as well as provide information on the completeness of the claims data that were used. We also have a section here wherein submitters input an authorized representative, or this is where an authorized representative is going to attest the currency, completeness, and accuracy of the data submission. So this authorized representative should be done by a chief financial officer, chief data officer, or other executive. The new section in the cover page is a section where carriers or submitters are asked to provide doing business names and federal employer identification number or EIN numbers. And this information really aids us in accurately collecting information, carrier information that we need to be able to calculate the net cost of administering private insurance, or the NCPHI. So moving on to the second tab, which is the total medical expense tab. In this tab, the data would be provided. The data that should be provided in this tab should be grouped by the following groups: carrier code, reporting year, insurance category code, large provider entity code, age, and sex code. These codes can be found in the tab 6, or the reference table of the data submission template. So one of the data strata in the TME tab is the insurance category codes. And these are codes that are mutually exclusive categories that indicate for which business is the carrier reporting the data for. So these are the various insurance category codes. And I would like to emphasize that commercial has two categories. First is the category of commercial insurance category code for full claims. And this is where when carriers hold the entire medical benefit and has all the data. But if insurers holds part of the benefit and another part is carved out to, for example, pharmacy benefit managers or companies, or carve out some behavioral health spending, for example, to a different entity, then carriers are advised to estimate partial claims data for which carriers do not have access. So, for example, if you don't have like pharmacy spending from claims data on pharmacy spending paid for by the PBMs, then you can use like full claims data to impute what would be like the average pharmacy spending for this partial claims category. Another insurance category codes that we'd like to emphasize is the Federal Employee Health Benefits, and that is code 7 and 8 for full claims and partial claims. We'd like to emphasize that these codes are only for carriers that cover a portion of benefits for a group of members, while another carrier covers the other portion of the benefits. So those that are split in nature. So if you do not share coverage of FEP members with another carrier, please categorize FEP spending under commercial insurance categories or insurance category code 3 or 4. The TME data are also stratified by age and sex groups, and that is so we could calculate the age-sex risk adjustment that we need for calculating the cost growth. So we would like to advise or continue to advise carriers and other data submitters to continue to submit spending even if there's no age or sex stratification in the claims data. So if that is the case, then the sex code that would be used for unknown would be 3, and the age band code for unknown would be 9. Another important data stratification variable is the large provider entity code. And this is really important because if we don't have data on this one, we won't be able to calculate data by providers. So this one requires carriers to do attribution. So we will talk about the attribution method in the next slide. All right, provider attribution methodology. The way we do things is that first we attribute individual members to a primary care provider. And attribution to the primary care provider is based on, number 1, member selection. So this means that members who were required to select a PCP by plan design should be assigned to that PCP first. And then for others who don't have PCP selection by plan, the next basis for attribution would be if the members were assigned to a PCP pursuant to a contract between the provider and the carrier, then that should be the next basis for attribution. Then for the rest of unattributed members, the next basis would be on utilization history. So for the remaining, the PCP attribution should be based on the members' utilization histories, and carriers may apply their own primary care-based methodology when attributing a member to a PCP based on utilization. So if members are not attributed based on these three criteria, then these members would be categorized as unattributed to a PCP. So once attribution is done to a primary care provider, then those members, these individual members, would be attributed to the large provider entity based on the association of the PCP to the large provider and to the large provider entities. And the list of large provider entities monitored by the cost board is contained in the next slide. And so we have 33 large provider entities, and they have unique large provider entity code from 101 all the way to 133. And if the member or the member month is not attributed as mentioned earlier, the code for that one should be large provider code equals 999. I would also like to point out that there is a large provider code 100 here, and this really refers to like the overall provider entities associated to a carrier. And for the TME tab, would like to emphasize that carriers don't need to provide total medical expense data for this code, large provider code 100, in the 2 TME tab. However, I would like to emphasize that this code would be needed in the standard deviation tab, wherein carriers are going to provide standard deviation by like for the overall carrier, because that is needed to be able to calculate the cost growth confidence interval for the overall carrier. And we will explain that in the next slides. All right. For data, we'd like to emphasize that data should only be restricted to Washington residents. So we are only collecting spending and member months data on Washington residents. Also like to emphasize that data on spending should be in allowed amounts. That means that it includes the amount paid by the insurer as well as the cost sharing paid for by the members. We should, carriers should also submit spending on claims for which the insurer was the primary payer. Carriers should also allow for claims runout period and a non-claims reconciliation period of at least 180 days after December 31 of the performance year. However, if there is like a runout period that is greater than the 180-day period, then carriers should use the maximum amount of runout time so that carriers would submit the most recent data. Carriers should also apply reasonable and appropriate incurred but not reported or incurred but not paid completion factors to each respective TME service category. Last but not the least, submitters should also apply reasonable and appropriate estimates of non-claims liability that are expected to be reconciled after the 180-day period. And I would like to hand over the presentation to Ross, who's going to explain how submitters should treat healthcare spending of Washington residents on healthcare services received out of state, as well as continue explaining the different service categories spending in the TME tab. Ross?
Thank you, Cheryl. So we received this question a few times last year, and so we wanted to make a chart, and we put this chart in the technical manual, and I'm going to talk about it a bit now. The question was around if there is spending for a non-Washington provider, how is that accounted for in the data? Well, one of the things is the first step is, are the services they provide paid for by Washington carriers? If yes, then it needs to be determined whether Washington residents saw a primary care provider within the provider. And if that answer is also yes, if that provider is one of those in the large provider entity list that Sheriel talked about earlier, then their spending will be in one of those large provider entity code. However, if one of those questions was no, then all that spending would just not be provided to a large provider entity. It'd be a 999 in the data. Next slide, please. Next couple of slides are going to talk about some inclusion criteria and some exclusion criteria. I'm only going to do a overview of it. There's more details in the technical manual, so please refer to that. And again, we're happy to answer any questions you might have. So for included policies, the main thing we are looking for are full coverage policies, whether those are like self-insured plans, even if they're short-term plans. We're looking for policies that cover all aspects of health. And so this is things like PEB/CEB, as well as managed Medicare Advantage plans, special need plans, as well as Medicare medical savings account plans, as well as Medicaid and CHIP managed care plans. Next slide, please. So in contrast, the plans that we are not looking for in the data are limited benefits. So things like accident policies, disability policies, long-term care insurance, Medigap, standalone prescription drug plans, dental-only insurance, vision-only insurance, those types of things. Next slide, please. So next, I'm going to talk a little bit about the data fields you'll see after the stratification fields. The first one is TME07, number of member months. We have this listed as a non-negative number. Some submitters prefer to submit as an integer. Some prefer to submit as a decimal. Either way works for us. For TME 08 through 15, this is all the claims-based spending. And so this is going to be a non-negative number, so anywhere from 0 up. TME 16 through 21 are all non-negative numbers. These are the non-claims-based spending. We do have two exceptions here. TME 17, non-claims performance incentives, may be non-positive. We had some numbers that were not very large negative numbers, but some existed. So we've updated our methodology to allow for that, as well as recoveries should always be reported as a non-positive number, because that's money that is coming back. And so we need to make sure that that is indicated by the way it flows, much in the same way as when we talk about pharmacy rebates, those will be reported as a negative number as well. Moving on to the truncation columns, TME 22 is the total truncated claim spending, and this is the only column that will have truncated claim spending in it for the TME tab. And we will talk more about how to report truncated claims in a little bit. And then TME 23 is an integer, so the count of members who were truncated. And this just gives us an idea of how many members account for truncation that needed to occur in the claim spending. Next slide, please. Now I'm going to go over a little bit more in detail, but again, please refer to the technical manual and then reach out to us if you have any other further questions on these. So for the first one, claims hospital inpatient is going to be the sum of the allowed amount from claims for hospital inpatient services. And so this includes things like room and board and ancillary payments for all hospital types, payments for emergency room services when the member is admitted to the hospital in accordance with the specific carrier's payment rules. This does not include payments made for observation services, payments made for physician services provided during an inpatient stay that have been billed directly by the physician group practice or an individual physician. It also does not include inpatient services at non-hospital facilities. Next slide, please. Next up, we have outpatient claim spending. And so this is the sum of the allowed amount from claims for hospital outpatient services. So this includes all hospital types and payments made for hospital licensed satellite clinics, emergency room services not resulting in admittance, as well as observation services. This does not include, much like inpatient, payments made for physician services provided on an outpatient basis that have been billed directly by a physician group practice or an individual physician. Next slide, please. Now we're getting to one of the updates. So primary care providers, this is the sum of the allowed amount from the claims paid to primary care providers for primary care services, but we are using the taxonomy, procedure, and place of service codes that are found in Appendix A of the implementation manual. So that will be the main new thing to everyone who has worked on this in previous years. Place of service has been added as a way to determine primary care claim spending. So please update the definition that you're using from the OFM expenditure report, and please use the advisory committee on primary care's definition. We do have that definition in the technical manual. However, I do encourage everybody to go to the primary care advisory committee's website. They have more information on there as well as an Excel sheet. And I know sometimes importing numbers from a PDF, not very easy. So the Excel file might be a little bit easier for that. Next slide, please. We have specialty care providers. And so this is the sum of the allowed amount from claims paid to physicians or physician group practices that are not defined as PCP, and includes services provided by a doctor of medicine in clinical areas other than family practice, geriatrics, internal medicine, and pediatrics, as defined by the primary care definition. Next slide, please. And then we have professional other providers. And so this is the sum of the allowed amount from claims paid to a licensed practitioner other than a PCP or a specialty provider. So as an example, if there's a PCP that rendered a service that is not included in the primary care definition, that claim would go here. That spending would go in this column. And so this includes things, but is not limited to nurse practitioners, physician's assistants, speech therapists, psychologists, dietitians, chiropractors. And this includes any fees that do not fit the other two categories, including facility fees of community health center services and freestanding ambulatory surgical center services. Next slide, please. We have long-term care. And so this is the sum of the allowed amount from claims paid to healthcare providers for skilled or custodial nursing facility services, hospice, homemaker and chore services, home health services, self-directed personal assistant services, among others. However, this does not include payments made for professional services rendered during a facility stay that have been billed directly by a physician group practice or an individual practitioner. Next slide, please. Retail pharmacy is the sum of the allowed amounts for the claims paid to retail pharmacies for prescription drugs, biological products, or vaccines as defined by the carrier's prescription drug benefit. This should not include claims paid for pharmaceuticals under the carrier's medical benefit. Pharmacy payments made under the medical benefit should be attributed to the setting in which it was delivered, such as drugs delivered in the hospital inpatient setting should be attributed to the claims hospital inpatient category. Medicare Advantage carriers that offer standalone prescription drug plans, PDPs, should exclude those PDPs spending from their reporting. And pharmacy data should be reported gross of applicable rebates. We have another section we'll talk about later where we ask for the rebate values. Next slide, please. The last claims category we have is other, and so this is the sum of the allowed amount from the claims paid to the healthcare providers for medical services not otherwise included in other categories. And so this includes things such as durable medical equipment, hearing aid services, optical services, payments made to members for direct reimbursement of healthcare benefits and services may be reported in claims other if the carrier is unable to classify the service in another category. Next slide, please, and we'll start talking about the non-claims-based payments. We have capitation or bundle payments, and these are all non-claims-based payments made to cover healthcare services. So things like capitation, global budget, case rate, episode-based payments, those sorts of things. We also have performance incentive payments, all payments made to providers for achievement of specific predefined goals for quality, cost reduction, or infrastructure payments. And so this also includes things like shared saving distributions and shared risk recoupments. Next slide, please. For population health and practice infrastructure payments, these things include all payments made to providers to develop capacity and practice infrastructure to help coordinate care, improve quality, and control costs. This can include things such as investments into electronic health records or health information technology infrastructure. It also include patient-centered medical home recognition payments, as well as primary care and behavioral health integration payments that are not reimbursable through claims. We also have provider salaries, which are all payments for salaries of providers who provide healthcare services not otherwise included in claims and other non-claims categories. Next slide, please. And the last two non-claims categories we have are recovery and other. For recovery, these are all payments recouped during the measurement year as a result of a prior review, audit, or investigation, regardless of the time of the initial payment. Again, this field should be reported as a negative number and only report data in this column that is not otherwise included elsewhere. As an example, if inpatient hospital is reported net of recovery, do not separately report the same recovery amount in this column. And then the last non-claims category, other. So all payments made pursuant to the carrier's contract with the provider that were not based on a claim for healthcare benefits or services, and that cannot be properly classified elsewhere. And so this may include things like governmental payer shortfall payments, grants, or other surplus payments. It may also include Medicaid transformation project payments made directly by carriers to providers. Also, only report payments made to providers here. Carrier administrative expenditures, including corporate allocations, are not included in TME. And now I will hand it over to Kathy.
Thanks, Ross. So I'm going to talk about the last two fields in the TME tab and then the standard deviation tab. This is a smidge more technical. Somehow the new person got the technical stuff. Don't know how that happened. So the last two fields in the TME tab are the truncated spending fields. They're the only fields with truncated spending on this tab. The total truncated claim spending, and then the number of members who have their spending truncated. So truncation just means that we are not including spending over a certain threshold. What that does is that means that a few high-cost members are not going to skew carrier or provider growth rates potentially upward. Truncation is applied on all claims spending, so it is claims spending. If you have commercial partial claims, you should include your estimates for carve-out benefits before you do the truncation, and truncation is done on a per member basis. And we'll do an example in a moment. Next slide, please. So the truncation threshold varies by insurance category. So Medicare and Medicaid insurance categories have a truncation threshold of $125,000. And for commercial categories and federal employee health benefits, that threshold is $200,000. Next slide, please. So just thinking about the calculation, one common thing that we've seen in previous data calls, data submissions is sometimes folks submit the amount above the truncation threshold. What we're really interested in is the amount below the truncated threshold, below the truncation threshold. And you sort of truncate on a per member basis, give us the number that's below the truncation. Well, take the number that's below the truncation threshold, add that up, and that's the number that goes in TME 22. That's that total truncated claim spending. It also ends up in SDO6, which we'll talk about in a minute. Next slide, please. So we'll do an example of a calculating truncation. So suppose that we have the following set of claims. And so the first thing we do is we notice that these are commercial claims. And so we go find the table with all of the truncation thresholds, look that up, and see that the commercial full claims has a threshold of $200,000. Then we go down and we look at our per member spending. So that's the first row of the table. And we compare that to the threshold. And we see that members 1, 2, and 3 have no spending above the threshold. Member 4 and member 5 do have spending above the threshold. However, the amounts we're really interested in are the amounts at or below the threshold, which is the last row. And so in that last row, we are looking at the actual spending for members 1, 2, and 3, which is that 150, 175, 200,000. Members 4 and 5, we're only going to count 200,000 of their spending because that was the truncation threshold. That gives us a total claim spending of 925,000 for that, for this set of members, instead of the untruncated amount, which was a million, sorry. And that 925,000 is what would get reported in TME 22 and SD 06. And then in TME 23, you just tell us how many members you had to truncate. In this case, that would be 2 members who were truncated. Next slide, please. That finally finishes the TME tab. The other tabs are not quite as long in terms of columns. So the standard deviation tab is where you're going to give us standard deviations. So the calculated fields in this tab are member months, total claims truncated spending, which should match that TME 22 when it's aggregated appropriately, and then standard deviations, which we'll talk about that calculation in a minute. The stratification variables here are carrier code, which will be the same, right, for your whole sheet. Reporting year, market code, we'll talk about market in a minute, and the large provider entity codes that are more or less the same as they were on the TME sheet. All right, next slide, please. So we ask for standard deviations because we're going to use this to calculate a confidence interval on the growth rates, so that we can say, you know, if someone seems to be at or above the growth rate or above the benchmark or below the benchmark, that yes, we're reasonably certain that that's actually there and not just statistical variability. So on this sheet, we're asking that you include the standard deviation for each large provider, including unattributed members under provider code 999, and the overall carrier standard deviation using large provider code 100, so that you do use that large provider code 100 on this tab. And we do ask that you include that large provider code 100, even if there is only one provider for that particular market and year. The code just works better that way. All right, next slide, I think. Yes. So just briefly, an example of the stratification that you'd have on the SD tab. So suppose that we have a carrier who in a particular year just operates in the Medicare and Medicaid markets. Then you would have, with the number of providers in the table, you would have 2 rows on your SD tab for the overall standard deviation in those markets. The Medicare market would have 4 additional rows, 3 for the large providers and then 1 for 999, where the 2 non-large providers are grouped together. And then the Medicaid market would have 2 rows for the 2 large providers. And so that gives us a total of 8 rows overall. And I think next up, nope, market codes. Sorry, forgot there were market codes. So this tab is aggregated by market rather than insurance category code, and that's just a slightly higher level aggregation. So Medicare, the duals and non-duals get lumped together into market 1. Medicaid, again, duals and non-duals together. Full and partial commercial together. And then please note that the federal employee health benefits split among 2 carriers are their own market. That's market code 4. All right. So now we're going to talk a little bit about calculating that standard deviation. So you want to use the average monthly spending amount, and we'll do an example in a minute, of each member. We want to base that on claims-based allowed amounts, so exclude non-claim spending. It should be based on spending after partial claims adjustments, so add in those partial claims, and after truncation. So you use truncation to truncated amounts to calculate this standard deviation. And I think the next thing is to look at an example. And so I'm going to go ahead and steal screen share back, or not steal it back, but steal screen share. And Hopefully you're now seeing an Excel spreadsheet. Okay, nods, that's good. So we have a hypothetical example here, simple example. Suppose that we had 3 members for this particular carrier in this particular market and year. Member 1 has very consistent spending. Member 2, little less consistent, also only a member for 5 months out of the 12. And then member 3 has a little spending at the beginning of the year, but none after that. And if we calculate average monthly spending, member 1 and member 2 have the same average monthly spending, of course, over different numbers of months. And then member 3's average spending is a bit lower because they just had that one large claim at the beginning of the year. It might be tempting at this point to calculate a standard deviation by doing the calculation in column I, where you say, well, here's all the monthly spending for member 1, here's all the monthly spending for member 2, here's all the monthly spending for member 3. I have Excel calculate a standard deviation, and I get a little under 100. It turns out that's not the standard deviation we want, and it has to do with the fact that we're looking at confidence intervals for growth rates here. And the standard deviation we want is actually the standard deviation of the average spending per member. And so the calculation we actually want to do is the one over here in column J. Looks the same for member 1, but you'll notice for member 2, we replaced the actual monthly spending with the average. And for member 3, it's really obvious, right? We replace that actual monthly spending with the average for each of those months. This has the effect of weighting by member months. It's equivalent. The gory mathematical formula is also in the technical manual if you like your formulas mathematical and gory. But we want to calculate a standard deviation of this column J, and you can see right away that it's going to be smaller. And it is. This is good old the population standard deviation function in Excel. Population because we want to divide by n, the number of member months, rather than n minus 1. But you can see that this standard deviation is a little under 30 rather than being a little under 100. So it's much smaller. And so in general, your standard deviations are probably going to be smaller than you think they are, or that you think they should be. And it's because we're taking standard deviations based on that average rather than taking standard deviations based on the whole. And with that, I'm going to hand it over to Ross and not Ross, Marty, the other Ross. And it'll just be a second while we get the screen share rearranged.
All right. I think we are seeing maybe the wrong screen. We
Are we back
also...
now?
There we go. Beautiful. All right, cool. But yeah, just going to cover the last 3 tabs, starting with tab 4, the line of business and role. Pretty straightforward, just 4 columns of data stratified by carrier code and line of business category that we talked about before. And then just having 2 additional columns that cover the aggregated member months for 2022 and 2023. And when you open the template, you'll find that the second column will be pre-filled with each of the lines of business already. Okay, next slide. Okay, in tab 5, you will report prescription drug rebates, starting with carrier code, year, and ICC stratifications. And then we ask that rebates be reported as negative numbers, and you should always have a total pharmacy rebate in RxR06. But if you're able to separate out between medical and retail RX, please do so in 4 and 5. And when you do that, make sure that 4 plus 5 equals the 6th column contents. Okay, next slide. Reference tables we already went over, but really quickly, the ICCs, market codes, line of business codes, age band and sex codes, large carrier provider or large providers and carriers, as well as the valid years, which in this submission will just be 2022 and 2023. Okay. Now, once you have the template filled out, we ask that you double check your work. While our team will thoroughly validate the data post-submission, you can reduce the amount of time spent in communication with our team and the time spent resubmitting data by running some simple checks to ensure submitted data is consistent and reasonable. And we'll go over some of the recommended tests in the next few slides. Okay. Now, firstly, make sure that your data is consistent, and there are places in the template where you are reporting the same aggregated data. So in the case of TME 22, as Kathy had mentioned, the truncated claims spending, that will also be carried over to SD06, the total claims truncated spending. Similarly, TME 07, the number of member months on the TME tab should be equivalent to the column in the standard deviation tab for member months, and then those should be equivalent to the enrollment by line of business in the fourth tab. And note that in that last one, because it's stratified by the lines of business, you'll want to aggregate those together to compare to the TME and standard deviation tabs. Okay. And then also by, likewise, it's useful to run checks on trends. So we ask that you're checking member months and spending trend-wise, but also total spending per member per month spending and year-over-year changes. So while change is a constant in the healthcare field, large changes could signal an inconsistent aggregation, or it could signal a change in business, such as moving into or out of a market. And certainly, of course, be aware that low member counts in certain rows could certainly lead to large changes in percentages year over year. Next slide. And then finally, pay special mind to consistency in the standard deviation tab. Large swings will impact the confidence interval while estimating overall spending growth rate. Okay. And next slide. And finally, we'll go over some of the logistics of data submission. We went over some of this information earlier, so we'll go through it relatively rapidly. Okay, so in terms of when to submit, they're due on April 18th, 2025, and we'll send a reminder 1 week and 2 weeks before the deadline. Now make sure that when you're submitting the data, it's submitted to the data email address, HCA cost board data at hca.wa.gov, not to the general board inbox that's listed there. Okay. And when using the data submission template, these are some things not to do. Make sure not to create new columns or change column headers. And make sure that if you're adding any columns or row totals to any of the tabs to check your work, you delete those previous to submission. So one thing to note is that we do have extensive conditional formatting that will be running some data checks. So if you're doing something wrong, such as spelling out a particular provider instead of a provider code in certain columns, then you'll see that the cells will turn red. So as I mentioned before, make sure that any additional calculations are deleted prior to submission. And then the file should follow the following naming convention: carrier code, carrier name, _TME, _4-digit year, 2-digit month, and 2-digit date. And also make sure that if it's a resubmission, that you'll want to update the file name to reflect that change. So the day that you're filing the resubmission. Okay. Now the submission process. Now, as I've mentioned before, we'll be doing some validation internally, checking for making sure that the data types are correct, data is consistent year over year, that the trends make sense, and cost growth outliers will be investigating and asking questions if needed, as well as other checks. And if we contact you with any issues and questions, and resubmission will be necessary, you'll have 1 week to do so. And so this, expect an iterative process where we're working with you to clarify any questions that we might have until we are finally able to fully validate and accept the data. Okay, and if you need any help, again, that email address is the HCA cost board data at hca.wa.gov. And we've also set up some times for you to privately consult with the board staff using an office hour system. So you can make appointments within these 2-hour windows across 5 different days. And in order to meet with us, make sure to email the data inbox directly beforehand. And appointments will be available first come, first serve. Okay. And any questions that we can answer?
And if you do have questions, please raise your hand and we'll promote you to panelist. You'll be able to speak and get your answer. Looks like we have a question from Robin. 1 second, Robin. And Robin, you should be able to talk now.
Okay, sorry, can you hear me first?
I can, yeah, go ahead.
Perfect, thank you. So I know there's that additional layer with the place of service codes being added for the PCP definition this year. For the items, assuming all else equal, like from the previous submission for the people that are no longer PCPs with this new additional layer, would that spend be expected to be captured in the specialist bucket now, since they're no longer PCPs? Is that a correct interpretation?
So that will so the specialty category is a little bit vague because we do not have a defined definition of what specialty care is, and so that's going to be up to the submitter whether it's defined as specialty care or other professional care, since it is professional services.
Got it. Yeah, perfect. Thank you. But I think the biggest thing was, like, I know it was clear it wouldn't go into outpatient spend based on what was mentioned for outpatient. Thank you.
Yeah, thank you.
Great question. We'll wait just a second to see if there are any lingering questions before we adjourn for the day. All right, seeing none, I think we'll wrap it up today. Thank you all again so much for coming. Really looking forward to this data submission process. And again, if you have any questions, please email that email, that cost board data email. Again, these materials will be posted on the cost board data call website, and feel free to contact us for private consultation during those office hour windows. Thank you all so much and have a great night. Bye.